Okay, so today we'll talk about nodular patterns, and we'll start with this case. It's a CT scan. What's the finding on the CT?
Bilateral nodules.
Yes, so there are bilateral nodules, but there's also one other thing to notice about these nodules, and what's the other thing to notice about the nodules there?
Actually calcified.
Yeah, so they are calcified. So what's the most common thing to give you bilateral calcified nodules?
Mets.
That is not the most common thing to give you bilateral calcified nodules. No. What is the most common thing to give you bilateral calcified nodules? Sarcoid? No. How about plain old, what's the most common thing to give you a calcified nodule? You see it every day on the chest rotation.
Oh, just like granuloma.
Yeah, calcified granulomas. So could these be calcified granulomas? What underlying disease would give you calcified granulomas? You can play too. So certainly tuberculosis, fungal infection, that can give you calcified granulomas, right? So that's one thing to consider. You might also have hamartomas that can calcify. Is there a condition associated with multiple hamartomas?
Yes.
What is that? Neurofibromatosis? No, that's not associated with Carney's triad. What is Carney's triad?
Gastric leiomyosarcoma.
Yeah, so gastric GIST tumors of the stomach, multiple pulmonary hamartomas, and paragangliomas, extraadrenal functioning paragangliomas. Okay, so that might also give you this. However, you mentioned one other thing. You mentioned Mets. So what kind of tumors would you be thinking about?
Osteosarcoma.
So metastatic osteosarc, what other tumors can calcify when they metastasize to the lungs? So there's osteosarc, there's chondrosarc. Yeah, mucin-producing tumors, also gastric cancer sometimes can also calcify. Treated Mets also can calcify. After Mets are treated, they might also calcify. So this patient had a PET scan that showed activity here within this nodule. You can see the activity there on the fusion, also a little bit down there. And this indeed was a case of, yeah, this was a patient with metastatic osteosarcoma. Usually in these cases, it's not a surprise. Usually we know that they have a history of osteosarcoma when we're reading the CT scan of the chest. Often it's done for metastatic disease, but the point is, in a patient with this history, if you see a calcified nodule, don't assume it's a granuloma, that it could be metastatic disease from osteosarcoma. Okay. Now, other things that can also give you calcified nodules, so multiple small nodules like this that are calcified, what infection can do this? Which one? Histoplasmosis, yeah. So histoplasmosis is inhaled. When it's inhaled, that epidemic form can spread throughout the lungs and the lesions can heal with calcification. So multiple calcifications like that can be from histoplasmosis. There's another infection that as a sequela can give you very tiny calcified nodules. So what infection as a sequela can give you very tiny calcified nodules? What is that? No, not pneumocystis. No, that does not give you calcification. Varicella. So as a sequela of varicella pneumonia, patients can also develop tiny calcified nodules. So on this chest radiograph, what do we see?
There's nodularity.
There's nodularity in the upper lungs or lower lungs? Lower lungs, right? And what do you think of the density of these nodules? Actually, they are calcified. These are pretty dense nodules. Okay. Now, there's another striking finding on the chest radiograph. What is that other striking finding there? What is this big thing in the center here? Okay, so can we take that a little bit further? What do we think the patient's underlying heart disease is? Why?
If you have like elevated right ventricular pressure, right.
Well, what are the findings? What are the findings on the chest X-ray that make you suggest rheumatic heart disease? Well, first, what is this guy over here? right? Is it abnormal?
It's enlarged.
Okay, so what would cause that?
It could be rheumatic heart disease, feeling.
Well, first tell me what would cause this appearance of a pulmonary artery. Anybody?
Pulmonary arteries,
What?
enlarged pulmonary arteries.
From what?
Pulmonary hypertension.
Okay, so the right pulmonary artery also appears enlarged, so you're thinking pulmonary artery hypertension, right? When we look in the upper lungs, we also notice what? What do we call this?
Congestion.
Yeah, there's some congestion here, right? So the term we use when the upper lobe vessels are more prominent than normal is called vascular redistribution or cephalization, all right? So that is a sign of what? It's a sign of pulmonary venous hypertension, all right? When you have this combination of pulmonary artery hypertension and pulmonary venous hypertension, then one thing that you would be thinking about is rheumatic heart disease. Are there findings in the cardiac silhouette itself that support your diagnosis? What would you look for?
Right ventricular enlargement.
What dilatation of the left atrium? So are there signs of dilated left atrium on the chest radiograph?
With double density sign?
Double density, right. So there's a double density here. That's the enlarged left atrium. So you have a patient with pulmonary artery hypertension and an enlarged left atrium. We think of mitral stenosis from rheumatic heart disease. And then how do we make sense then of these nodules? What do these nodules represent then in a patient with rheumatic heart disease and mitral stenosis?
Alveolar microembolism.
Not alveolar,
Calcified.
no, no. What do they represent?
I think
Calcifications, right?
What do we call it?
Oh.
Pulmonary ossifications. Pulmonary ossifications as a result of hemosiderosis that can be a complication of rheumatic heart disease, right? So from pulmonary venous hypertension, they can develop small areas of hemorrhage in the lung that go on to ossify. And so patients with long-standing rheumatic heart disease can also develop those types of calcified nodules. So your differential for multiple calcified nodules, TB histoplasmosis, calcifying metastases, sequela of varicella pneumonia, pulmonary ossification from mitral stenosis. Mets from osteosarc, as we've said, usually we know the patient has osteosarc when we're looking at the chest radiograph or the CT scan. So if you get that history, you cannot assume that a calcified nodule is a granuloma. It can be metastatic disease. Varicella pneumonia, when patients first develop kind of a bronchopneumonia from varicella, so they can have these multifocal areas of consolidation around airways, and then when they heal, they can heal with small, tiny calcifications. So tiny calcifications can be a sequela from varicella pneumonia. Calcified nodules from mitral stenosis, rheumatic heart disease, any patient who has a combination of pulmonary artery hypertension and pulmonary venous hypertension with evidence of an enlargement of the left atrium, you're going to think about rheumatic heart disease and mitral stenosis. In long-standing cases, there are some patients that can develop ossifications within the lungs. Okay? So we can see that from mitral stenosis also. This chest radiograph, what is abnormal about this chest radiograph? What do we have here? So there are bilateral diffuse opacities throughout the lungs, right? What can do that? You see bilateral diffuse opacities in the lungs. What do we think? What can do that?
Really bad pneumonia.
Okay, so extensive pneumonia, ARDS, really extensive consolidations. But there is another peculiar finding here when you look at the mediastinum. What do you notice? Sam, what do you notice there about the mediastinum?
Oh, well, I'm seeing, it appears to be air, actually.
So it's more lucid, right?
Yeah,
So you're thinking about what?
pneumomedius.
Thinking about pneumomediastinum. What do you think about the pleura out here?
Yeah.
What do you think of the density of the pleura there?
Yeah, well, that looks like pneumothorax.
So you think there's
large.
pneumomediastinum and pneumothorax.
Yeah.
What do you think of the
Right.
density of the abdomen here?
Oh. Right there, there could be also, well, again, lucency, so maybe pneumoperitoneum.
So you think this patient has pneumomediastinum, pneumoperitoneum, and pneumothorax?
I know that does sound a little ridiculous.
What's the densest structure on the X-ray?
The bones.
Bones, what else?
Else. Looking for, oh, well. we do
How about
have
the
lines-
lungs themselves?
Oh, well, yeah, they are very dense.
The
yeah.
lungs here are very dense, right?
Yeah.
So that is why the mediastinum looks lucent, the abdomen looks lucent, the pleura here looks lucent. So what could give you that appearance of the lungs?
Fibrosis.
Fibrosis is not going to make the lungs denser than the mediastinum. Hemorrhage will not make the lungs denser than the mediastinum. Hemorrhage is soft tissue attenuation, right?
It's gonna be maybe diffuse, I don't know, like diffuse.
Are the bones denser than the
Calcification.
mediastinum?
No, they're not.
The bones are not
Wait,
denser
no,
than the
the bones are
mediastinum?
denser than the mediastinum.
What is it about the bones that makes them denser than the mediastinum?
Calcium, right?
Okay, that's right.
It's calcification.
So when we look on the CT, what do we notice about the lungs?
They're calcified.
They are diffusely calcified, right? And so when we're looking at the pleura, really they're pleural effusions here in this case, and that's why we see that lucency out there. So the lungs are actually denser than the pleural fluid because they are diffusely calcified. So what condition might do this?
This is diffuse microlithiasis.
This is, it's called pulmonary alveolar microlithiasis. Yes. Pulmonary alveolar microlithiasis can give you extensive calcifications like that of the lungs. And a characteristic finding of that on bone scan is,
Really active.
because of the active calcium metabolism there in the lungs, you have this increased activity within the lungs on the bone scan. So that's also a very peculiar finding associated with alveolar microlithiasis. So this is a rare disease. It's characterized by these calculi that form within the alveolar spaces. There is a familial form of this. It's autosomal recessive. Peak age 30 to 50. Patients are usually asymptomatic. The X-ray tends to look worse than the patient, but there are cases when it can progress to respiratory impairment. Classically, on the chest X-ray, you get what's called a sandstorm appearance. So you get these it's like somebody sprinkled sand on the X-ray, and so you have these tiny, dense particles scattered throughout the X-ray. It's not something that you think of actually when you look at the X-ray. I mean, you realize this is peculiar, but it doesn't hit you that this is, this is alveolar microlithiasis. It just looks like a peculiar interstitial-looking chest radiograph. But then this finding, the black pleural line, because the lungs are denser than the pleura, that is a pathognomonic finding associated with alveolar microlithiasis. And then it's easier on CT because on CT we can see all of the calcification, the diffuse small calcification scattered throughout the lung parenchyma. So that's pretty easy on CT. And then of course on bone scan, you also have increased activity on the bone scan. Another very unusual finding associated with alveolar microlithiasis. And we talked about the black pleural line. Sometimes they can have these little cysts, these tiny cysts that occur in the periphery that tends to accentuate that black pleural line, which is a radiographic finding also of alveolar microlithiasis. So this patient has this chest radiograph that shows these dense opacities at the lung bases, and the CT shows what?
Calcified nodules.
You're going to call those nodules masses, or is that what you're going to call them?
Is it 3 centimeters or more?
Tell me what you're going to call them.
But the
What?
air bronchogram.
Yeah, that's very peculiar, isn't it? There's an air bronchogram in there, right? They have air bronchograms. What does that mean?
Air consolidation.
Yeah, these are alveolar opacities. These are calcified alveolar opacities here, okay? So, now there is another finding here that might help you. Is there another finding that this patient also demonstrates?
Pancreatic head.
No, that looks pretty good, actually.
Large chest or,
What?
heart.
An enlarged heart? Yes, the heart is big, yes. But what's on that third image? Why did I give you that cut through the abdomen?
Like distended second portion of duodenum with contrast.
No, that's normal. Is there a particular organ on that, or organs that you do not want? You,
Spleen?
what? It's okay.
It's a liability.
Gallbladder.
What? Gallbladder? I don't see the gallbladder there. What are these guys? Do you want those kidneys? What's wrong with those kidneys?
Cortical infarcts?
No,
They're small.
they're small. Those are pretty small kidneys. So this patient has what? Well, bilateral small kidneys is going to be, that's not hard.
Chronic kidney disease.
Yeah, chronic renal failure, chronic kidney disease. Now, how does that help you? How do you put that together with the findings in the lungs?
Oh,
Is that calcium?
Hyperparathyroidism?
Yeah, and what does that cause? What do you call this? What do we call this?
Like secondary.
Hmm?
Secondary.
Well, what do we call the process that's happened that results in this calcification in the lung parenchyma?
Pathological calcification.
Pathological okay, so you're naming your own diseases there.
Oh, is it pulmonary?
This is called metastatic calcification associated with renal failure. So patients with renal failure, acidosis, hyperparathyroidism, these metabolic abnormalities, elevated calcium phosphate. So especially where they have acidic environments like the lungs and the stomach, they can develop calcifications. Actually, they can develop anywhere, even in the soft tissues. So patients in renal failure can develop calcifications within the lungs, anyone, and also anywhere else in their body. That's called metastatic calcification associated with renal failure. Okay, this chest radiograph, what does this demonstrate? What do we see here? What is abnormal?
Bilateral nodularity. It's like miliary.
Micronodular pathogen.
It's like miliary.
Yeah, so are these big nodules or small nodules?
Tiny.
These are small nodules, right? So we call this a micronodular pattern or a miliary pattern, right? So this is a miliary pattern on the chest radiograph. Of course, when you say miliary pattern, the first thing you think of is tuberculosis, right? Now, you can see the close-up, multiple small nodules there. On the CT, when you have a micronodular pattern on CT, there is an approach that we're supposed to take. What is that approach?
Oh, the distribution.
Okay, so
Fluorosparing or pleuroinvolving?
what are the three distributions that we try to think about?
Random.
Random,
Centrilobular,
centrilobular, and
lymphatic.
perilymphatic. Those are the three distributions. Now, you started to go through an algorithm about questions that you ask yourself. So the first question you ask yourself is, you say self,
Does
What
it
do you
involve the pleural or not, or is it adjacent?
are the nodules touching the pleural surfaces, right? So in this case,
Yes.
yes, what does that mean? Oh, you've answered the question, now what does it mean?
Random?
No. First, it means what?
It's not central.
It is not centrilobular, right? Which means you have two choices left, which are
Perilymphatic.
perilymphatic and,
Random.
now what is the next thing you look at?
Is it like bordering the fissures?
All right, so the next thing you look at is you look at the fissures, you look at the interlobular septate. Is it studying the fissures? Is there a predominance of nodules along interlobular septate? If the answer is yes, then you have what?
Perilymphatic.
Perilymphatic, right. What about this case? Is the answer to that question yes or no?
No,
Say no. What does that mean then for this case?
it's a random.
It means it's a random distribution of nodules. These different distributions also are associated with the pathophysiology of how the nodules got there, right? So when you have a random distribution of nodules, how did the nodules get there?
Randomly.
Hematogenous dissemination, right? So hematogenous dissemination gives you then a random distribution of nodules. Also, on the chest radiograph, right, if you had to decide are the nodules upper lung or lower lung, you would say lower lung, right? So a lower lung distribution of nodules also implies that it might be hematogenous from the chest radiograph. But so back to the CT. So given that, then what is in your differential diagnosis here? TB, what form then? We call that miliary tuberculosis. Yes, so that would be in your. Is there anything else you might consider?
There are fungal infections also.
Fungal infections, yes, there are fungal infections, so that can also give you hematogenous dissemination and a miliary appearance like that, which would be indistinguishable from tuberculosis as far as the imaging. Okay, is there anything else we would consider?
Malignancy, yeah.
Who?
Medicine.
What malignancy would you think about?
Um,
What is the malignancy that is notorious for giving you small nodules scattered throughout the lungs?
Yeah.
Which
Friends.
anyone can do it, but there's a particular one mentioned in the textbooks that you should be aware of.
Um,
Thyroid, yes, thyroid malignancy is the one that you think about, right? But any malignancy can do it. This particular patient, there's another image on their CAT scan that shows what?
liver mets.
Liver metastases. What's the most common tumor to metastasize to the liver? Colon cancer. This was a patient with metastatic colon cancer. Okay, any tumor can give you micronodular metastases. Thyroid is the one to think about, but any tumor can do it. In this case, it was colon. Okay, so what?
Is there a certain kind of thyroid cancer that typically?
Papillary.
Papillary, okay.
Okay, so another micronodular pattern. We go through. First question we ask ourselves is,
Pleura.
the answer is,
Pleura.
what's
No.
the answer?
It doesn't touch the
No?
I think it does in the debate. but-
Well, we're gonna have to answer that question first before we move on. So what do we think? Yes or no? So we see, all right, this touching the pleura?
Yes.
Yes, okay. These guys touching the pleura?
Yeah.
Oh, yeah, okay. So the answer is yes, that means what?
Not central.
Not central, which means we're down to,
Random,
and
paralympatic.
next question we ask,
Just a little bit studying.
and the answer is,
Yes.
well, so what's the distribution?
Paralympatic.
Yeah, so we have it studying the fissures here, the major fissures, also along vessels, also along interlobular septae. So that is a perilymphatic distribution of nodules. So a perilymphatic distribution of nodules is associated with what?
Sarcoidosis.
Anything else?
Pneumoconiosis.
A little bit less on your list, but what particular pneumoconiosis?
Cold.
Silicosis, but co-workers is the same, so those two go together, right, essentially. There is something else, though.
Lymphatic malignancy spread.
Yeah, what do we call that?
Lymphatic carcinomatosis.
Lymphangitic carcinomatosis, right. So lymphangitic carcinomatosis can also give you a perilymphatic distribution of nodules. Do we favor sarcoid or lymphangitic carcinomatosis in this case?
Sarcoid.
Why?
Highly lymphatic.
There's bilateral hilar nodes looking large, so you would favor sarcoid. There's another reason also why you would favor sarcoid over lymphangitic carcinomatosis. What is that? Hmm?
Symmetric?
Can't hear you.
It's symmetric. What is it?
It's symmetric? Well, lymphangitic carcinomatosis can be symmetric also.
upper lung versus lower.
If you had that, right, lymphangitic carcinomatosis tends to be lower lung, sarcoid tends to be upper lung. What about thickening of interlobular septae?
It's more smooth for sarcoid.
It's what?
It's like smooth for sarcoid.
No, actually, sarcoid tends to be nodular. But do you have much in the way of interlobular septal thickening here?
No.
No. Lymphangitic carcinomatosis gives you more interlobular septal thickening that tends to be nodular, whereas sarcoid gives you more nodularity. So the more nodular the disease looks, the more you would favor sarcoid, the more interlobular septal thickening there is, the more you might lean toward lymphangitic carcinomatosis. Clinically, of course, you usually have the information that the patient has tumor by the time we're evaluating them for lymphangitic carcinomatosis on the CT. This chest radiograph demonstrates what?
Multinodular.
Now, we talked about how we approach the micronodular pattern on CT. How do we approach the micronodular pattern when we're looking at a chest radiograph? What do we do there?
Distribution.
Well, what distributions do you divide it into?
Upper, lower.
Upper or lower? Right. Is this upper or lower?
Upper.
This is upper. So what is first, what would be your differential for a lower lung distribution of nodules if it were lower? What?
No, like hematogenous.
Hematogenous, in which case we think of what diseases?
Like metastatic spread.
But, well, first we would start with
Infectious.
What do we call that? Miliary TB, metastases, right, if it's lower lung. Now, this is upper lung. What is your differential here? What gives you an upper lung distribution of small nodules? Sarcoid is a good choice. Silicosis, that's another good choice, right? So those are two things that you certainly would think about. Something else, of course, to always consider when you have upper lung disease on a chest radiograph. That's not going to look like this, although that does give you upper lung disease on a chest radiograph. But here, of course, we have Lattimore Clinic.
TB.
Tuberculosis, right? So you might think about tuberculosis also, right? So this patient has nodules, but also demonstrates this interesting finding, which is called, these are called eggshell calcifications, right? You have calcified nodes in the periphery, and this is closely associated with, no, silicosis. Silicosis is you can get it with other diseases. The differential of eggshell calcifications, as long as we're on the topic, silicosis, most closely associated with silicosis, co-workers pneumoconiosis. You mentioned granulomatous disease, TB, right, can give you eggshell calcifications. And there's one other thing that only radiologists think about, well, sarcoid also, but there's one other thing that only radiologists mention, treated lymphoma, right. Treated lymphoma can also be associated with eggshell calcifications. But if we see it, we start with silicosis. Okay. Kind of a subtle finding on this case. What do we have? All right, well, let me give you a close-up there. What do you got? Yeah, we got one or more than one. Yeah, more than one. And the distribution is? Upper lung, right. Again, another case of upper lung distribution of nodules, right? And we mentioned in our differential, we said the things you want to mention are?
Silicosis, TB,
Sarcoid. Poll workers. And we've run out of stuff. Well, here's the CT on this case. What is this?
Bronchiectasis?
No. So these are cysts, and what else does the patient have? Cysts and, what do we call these? Those are nodules. So we have cysts and nodules in an upper lung distribution. What activity does this patient do? Smokes, right. So what is this? No. This is Langerhans cell histiocytosis, LCH, right. There's a particular sign that can also be associated with Langerhans cell. They start out as nodules, then they cavitate, and kind of, you might get this appearance where you have like that thickening of the periphery and that cavitary lesion. This sign, what is that sign called? No, it's not. The halo sign is ground glass surrounding the lesion. That is called the, who said it? Cheerio sign. That is the Cheerio sign that can be associated with LCH. Okay? All right. What?
Nothing. I said the wrong answer so we could learn.
Or maybe you can learn. So micronodular pattern, micronodular, miliary, and reticular nodular have the same differential diagnosis. You can also approach it this way. If the patient is sick, we think of infections, miliary TB, miliary fungal infections, some other infections. That can also give you a miliary pattern. As far as TB and fungal infections, when it's miliary, indistinguishable random distribution of small nodules on the CT scan. So both of those will give you that. Chronic, patient not sick, could be Mets, sarcoid, some of these other things that we've also mentioned and we'll talk about too. Of course, alveolar microlithiasis looks very different, as we kind of seen, we touched on before. The algorithm, if we have micronodular pattern, are they touching the fissures? If the answer is no, then we're dealing with a central lobular distribution. Then we think about diseases affecting the airways. If there's tree and bud, infections, TB, atypical mycobacterial infection, DPB stands for what? Diffuse panbronchiolitis, right? That's a pretty unusual disease. Even if they're not, even if you don't have tree and bud, you can still have infections, right? That can do it, and then some other things that are also mixed in there. Perilymphatic distribution, we think sarcoid, lymphangitic cancer. occasionally cases of pneumoconiosis like silicosis and co-workers pneumoconiosis, random distribution, Mets, biliary disease, biliary infection. That is the algorithm. Micronodular metastases, any tumor can do it. Thyroid, you want to think about. Then there are other tumors, but any tumor can give you a micronodular distribution. This was our case of metastatic colon cancer with micronodules on the CT, random distribution. For sarcoid, it's associated with the reticular nodular pattern, tends to be upper lung predominant, bilateral hilar lymphadenopathy. Symmetric bilateral hilar lymphadenopathy is a hallmark of sarcoid. Whenever you see bilateral symmetric hilar lymphadenopathy, regardless of what else you see in the chest, you've got to think about sarcoid. Okay, so if you see that, that's something to tip you off. And of course, you can also have multiple nodules, but the point about sarcoid is it tends to be associated with a perilymphatic distribution of nodules along interlobular septae, along fissures, along the vessels. So it's a perilymphatic distribution. So if you see nodules that are studying the fissures, nodules along interlobular septae, that is a perilymphatic distribution. And so that, of course, we see with sarcoid. LCH, this disease is associated with smoking. It gives you reticular nodular disease, mid to upper lung distribution. It can be associated with air trapping. So these patients can have increased lung volumes in addition to their interstitial disease. And so 1/3 will have increased lung volumes. Tends to be upper lung predominant. You can have nodules, cysts, interstitial pattern on the chest radiograph with Langerhans cell histiocytosis. In the beginning, it might be nodular, so it might be predominantly nodular if you happen to catch it at the nodular phase. You can have nodules and cysts, as these nodules tend to cavitate, and then when the cysts coalesce, if it progresses, then you develop emphysematous disease in the later stages. So this can progress from nodules to cysts to emphysema, LCH. Silicosis, this gives you an upper lung distribution of small nodules. And of course, it's fibrotic lung disease caused by inhalation of silica dust. Mining is the occupation that is associated with this. And so what happens is that these get deposited in the alveolar walls. Macrophages try to ingest them, or they do ingest them, but the macrophages die, release their enzymes, and that's why you develop the fibrotic nodules from silicosis. They can also travel to the hyla. The macrophages travel to the hyla, which is why you get lymph node changes. So you can have somewhat enlarged nodes, and you can also have lymph node calcifications, that eggshell calcifications of lymph nodes associated with silicosis. When the nodules coalesce, you can develop larger fibrotic masses. That's called PMF. PMF stands for what? No, not pulmonary. Progressive massive fibrosis, right? PMF stands for progressive massive fibrosis. So you have nodules, and then when the nodules coalesce, they can coalesce into these larger fibrotic masses, progressive massive fibrosis. So it tends to predominate in the upper lungs. It's thought to be due to a less efficient lymphatic drainage from the upper lungs, which allows the particles to accumulate in the upper lungs. These patients have an increased susceptibility to tuberculosis also, patients with silicosis. This was a 29-year-old with shortness of breath, very peculiar looking chest radiograph, had the history of working in a diamond mine, and the CT shows this. What is it that we see on the CT?
Below predominance, like consolidating opacities.
Yeah, so you have these, right, you have these airspace opacities, somewhat upper lobe predominant. There's something peculiar looking about them, though. What is that?
Central distribution.
What's that?
Central distribution.
Yeah, they kind of have that central distribution. This is a very nice demonstration of a particular sign. This is the angel wing sign. See it? So the angel wing sign means what? Well, what do these masses represent?
Fibrosis.
What does PMF stand for? This is PMF, progressive massive fibrosis. And that can give you the angel wing sign. These masses tend to contract towards the hyla, And as they contract towards the hyla, the lateral borders there can kind of be parallel to the pleural surface and give you the angel wing sign, right? But he's very young to have this, so what do we call this? There's a term we would use to describe this form of silicosis. What would we call it? Remember, silicosis usually takes years. This person is very young. So if it's faster, if it occurs faster than it should have, it's called
Rapid.
not rapid. What? Accelerated silicosis. Very good, yes. So terms you need to be familiar with: acute silicoprognosis, simple silicosis, accelerated silicosis, complicated silicosis in Kaplan syndrome. Acute silicoprognosis with a massive exposure, usually sandblasters. These patients can develop alveolar proteinaceous exudate like pulmonary alveolar prognosis. That gives them consolidations within the lung, and the disease can progress rapidly. But this is an acute massive exposure, acute silicoprognosis. So they have kind of ground glass consolidations within the lungs, usually sandblasters. Okay? So acute silicoprognosis manifests within 3 years of a massive exposure, as we said, usually sandblasters, consolidations, nodules, and so they get that, but of course it occurs very quickly after the exposure, as opposed to years, which is the usual case with other forms of silicosis. Simple silicosis, these patients just have nodules. The latency period is 10 to 20 years. This usually does not result in any deterioration of lung function. The disease can progress even if no longer exposed. Complicated silicosis, when the nodules coalesce to form these larger fibrotic masses, so greater than 1 centimeter is the criteria, that is associated with symptoms and disability. So if you have nodules greater than 1 centimeter from coalescence of nodules, that is complicated silicosis. Accelerated silicosis, caused by high exposure to high concentrations over a short period of time. We can see this in the United States too, in stone workers, people who are making countertops. From a large exposure, they can develop changes of silicosis rapidly in just a few years, as opposed to 10 years, which is the usual case with minor. So nodules, upper lung distribution, silicosis. This is a coal worker with lung nodules. What do we call this? So what are the findings here that make you say Kaplan syndrome?
I mean, they have rheumatoid arthritis.
Yes, so they have rheumatoid arthritis, right? So you have a patient with rheumatoid arthritis who's a coal worker and develops nodules here within the lungs. What are those nodules? Those are rheumatoid nodules, right? These are necrobiotic rheumatoid nodules that occur in the lungs, so they kind of form in an accelerated fashion in patients who are exposed to coal or silica. So coal workers or pneumoconiosis or silicosis, patients with rheumatoid arthritis can develop an accelerated form of those necrobiotic nodules, right? So those are rheumatoid nodules. That's called Kaplan syndrome. Simple silicosis, small nodules. Nodules might calcify. We discussed eggshell calcifications. That is also associated with silicosis. So nodules, especially upper lung distribution, can be silicosis. Eggshell calcifications, of course, that also is associated with silicosis. So the nodules may be centralobular or sometimes perilymphatic, so it kind of falls in the borderline there with silicosis. What do we see here?
Upper lobe predominant opacities.
Yeah, we have these bilateral upper lobe predominant opacities. What do you think these opacities represent? Do you think this is cancer?
No, it looks like scarring with like.
Right, so why do you think it's scarring?
There's like volume loss in these reticular opacities, a particular disease.
Yeah, so the hilum are elevated. You can see the stretched vessels here within the lower lungs. So these then represent fibrotic masses. This is another case of progressive massive fibrosis. Another case of silicosis with progressive massive fibrosis, nice eggshell calcifications here, okay? So that's complicated silicosis. Nodules greater than 1 centimeter from as you get coalescence of those smaller nodules, and these kind of contract towards the hyla and can leave behind peripheral emphysematous lung. You can get the angel wing sign. as the lateral borders might be parallel to the pleural surfaces. And you might also get cavitation in these things, and these patients are also susceptible to tuberculosis. And here's a very nice example of angel wing sign from progressive massive fibrosis. Very nice examples of eggshell calcifications. So this is a case of silicosis with progressive massive fibrosis. Notice the emphysematous lung in the periphery. This leads to, of course, decreased lung function. As these masses contract, they leave behind peripheral emphysematous lung. So you can see that here too. These cases of progressive massive fibrosis, they leave behind emphysematous lung, and that results in the impaired lung function in these patients. Complicated silicosis, they are susceptible to infection with tuberculosis, and the deterioration of lung function correlates with the associated emphysema that these patients can also have. Cavitation, we can see that. That can occur on its own, or it can occur with superinfection with tuberculosis in these areas of progressive massive fibrosis. Okay. Now, cold-workers pneumoconiosis, the good news is, even though this is a different disease, you don't have to learn anything different about it. It is radiologically identical to silicosis, so you can store those two diseases on the same neuron. They go together. So the pathologist can see the coal macule, the accumulation of coal around there, but we're not going to see that. It's going to look the same as silicosis does. The coal macule is the pathologic lesion that is associated with cold-workers pneumoconiosis, but radiologically, for us, it is indistinguishable from silicosis. You can have simple cold-workers pneumoconiosis, small nodules, complicated progressive massive fibrosis, respiratory impairment, usually not as severe as silicosis. And the findings, of course, same as silicosis. Simple, nodules, complicated, progressive massive fibrosis as you get coalescence of the nodules. Now, as long as we're talking about pneumoconiosis, let's touch on inert dust pneumoconiosis. So these are dusts that do not cause fibrosis in the lung, but because they're metals and they're very dense, the X-ray looks horrible. So iron, tin, barium, these things, when they're inhaled in the lung, they're very dense particles. They don't cause fibrosis, but the X-ray looks like you see all these very dense particles of metal. This is stenosis. So these are inorganic dusts, no fibrotic response, dense reticulonodular pattern there on the chest X-ray because they've essentially inhaled. What is the finding and the differential diagnosis? I want you to list your top 4. What is the finding here?
Micronodular opacities.
Where? We said that the approach on the chest radiograph was what? When you see micronodules, what was the approach?
Upper lobe or lower lobe.
Is this, and what is this?
Upper lobe.
Very good, you're on the right track, like a bloodhound, okay? So, give me the top 4 in your differential for upper lung small nodules. We've gone through this a couple times already, so let's hear your top 4.
Malignancy, like.
Well, no, that is not in your top 4. Upper lung distribution of small nodules. Remember, malignancy is hematogenous dissemination, so that should be upper or lower. Should be lower.
TB.
TB, yes, you could have tuberculosis, that can give you upper lung. Not miliary TB, but, you know, certainly the reactivation form. What else?
Silicosis.
Who?
Silicosis.
That's right, silicosis is in your difference. So you've got 2 of the top 4. Number 3, you're missing a big one.
Sarcoidosis.
Of course, yes, sarcoid, that's number 3. And there's another rare disease also that might be number 4. The patient smokes. What was that?
Histiocytosis.
Yes, Langerhans histiocytosis. So that might be your top 4 for this patient. Very good. But I will tell you that this person works in a factory that makes light bulbs. What do you have to say now?
Beryllium?
Berylliosis, correct.
Wow.
Berylliosis, yes. So berylliosis looks just like?
Silicosis.
No. There are similarities, but if you're going to store berylliosis on a neuron, you're going to store it as the same neuron as?
Workers?
No, sarcoid. Sarcoid. So borreliosis and sarcoid, put those two together. But if a case looks like sarcoid, don't start with borreliosis case. Start with sarcoid. Right? You want that history, occupational exposure, fluorescent bulbs, aircraft brake linings. There is an acute form that gives you consolidations, but we're not really concerned with that. We're talking about chronic borreliosis. Now, the interesting thing is they develop non-caseating granulomas, just like sarcoid. May form in the lung, skin, lymph nodes, liver, and spleen. The salivary glands, eyes, bones, CNS spared. Okay. CT can look just like sarcoid. Nodules, upper lung distribution, perilymphatic nodules, hilar nodes. So all the changes you get with sarcoid, you can also get with borreliosis. But please, please always say sarcoid first. And then if you're going to entertain the diagnosis of borreliosis, you want the history of the patient being exposed to that. Upper lobe nodules, perilymphatic nodules, borreliosis. This is actually a case from Newark. There was a light bulb factory here many years ago. And there were patients that came here with chronic borreliosis. So it looks like end-stage tuberculosis or end-stage sarcoid with upper lung fibrotic disease. Okay. Now, another example of parenchymal opacities, upper lung distribution. Do we think this is cancer? Why not? It's bilateral, somewhat symmetric. Yeah, upper lung. Minor fissures elevated, suggesting some architectural distortion. So we think this represents what? Well, what do we call the process when you develop those progressive fibrotic masses? We call it PMF, progressive massive fibrosis. So this patient has progressive massive fibrosis. What's this patient's underlying disease? Notice perilymphatic nodules, emphysematous lung in the periphery, somewhat of an angel wing sign. And these is also cavitary, right? What are these?
Eggshell calcification.
Those are not eggshell calcifications, no. Those are what? Those are not calcified. Those are just lymph nodes. Bilateral hilar lymphadenopathy. This patient has sarcoid, yeah. This is a case from here in Newark. This is a patient with sarcoid. Sarcoid can also give you progressive massive fibrosis. As a matter of fact, when the nodules coalesce like that to form these larger, when these nodules coalesce to form these larger masses, there's a particular sign that's associated with sarcoid. What do we call that sign? The galaxy sign, right? That's the galaxy sign of sarcoid. Yeah. You can see it with silicosis also. Whenever you get progressive massive fibrosis from coalescence of nodules, you can get a galaxy sign. Okay? Very strange looking. What do we have here?
Micronodular opacities throughout both the lung fields with.
You mentioned galaxy sign, right? So that implies this represents
Sarcoidosis.
no. The galaxy sign itself means that there's coalescence of nodules forming what? What do we call these? PMF, which stands for progressive massive fibrosis, right? So it's a nice galaxy sign. We do have progressive massive fibrosis. We did say we can see that with TB, we can see it with sarcoid, we can see it with silicosis. But what is very peculiar about this case?
Isn't the distribution of those nodules essentially lobular, right?
No, I really couldn't say. They don't seem to be touching the pleural surfaces, but they're coalescing, so it kind of distorts everything. Look at that second image. What's peculiar? You don't notice anything peculiar on the second image. What is this? It's very dense, right? Yeah. Looks like calcification. So you have progressive massive fibrosis of high attenuation, right? So what pneumoconiosis can give you progressive massive fibrosis of high attenuation? Talcosis, yeah, this is a case of talcosis. So talc has high attenuation. When the particles coalesce like that, you can have high attenuation within your areas of progressive massive fibrosis. So that is talcosis. What's wrong with this X-ray?
Diffuse micronodular opacities.
Somewhat reticular nodular, I would say, right? Distribution, upper or lower?
Symmetrical.
Somewhat upper, I would agree with that. One, yeah, and then biapical, kind of some pleural thickening there. Maybe even some fibrosis, right? One other finding overall, when you look at the X-ray, there's one overall finding you might notice. Yeah, there's hyperinflation, right? There's increased lung volume here, okay? And here is the CT scan. What does the CT show? Ground glass, right? And the distribution of the ground glass is central lobular, right? So what are we dealing with? This is hypersensitivity pneumonitis, right? You have central lobular distribution of these ground glass nodules. It's a case of hypersensitivity pneumonitis. And you can see on the coronal reconstructions, it is somewhat upper lung predominant. And what have we demonstrated here? What do we have here? Fibrosis manifested by, what do we call that? Traction bronchiectasis. There's traction bronchiectasis here. So there is fibrosis that is upper lung predominant in this case. So this is a case of hypersensitivity pneumonitis. Classic findings, another different case, but this is the classic finding. Central lobular ground glass attenuation nodules, classic for hypersensitivity pneumonitis. So this is usually caused by inhalation of an organic antigen that results in inflammation around the central lobular bronchioles. That's why we get that central lobular distribution of ground glass opacities. And on pathology, there's kind of a cellular bronchiolitis on pathology, poorly formed non-necrotizing granulomas around the central lobular airways. The diseases named by the source of antigen: farmer's lung, bagasosis, humidifier lung, pigeon breeder's lung, and hot tub lung. It's associated with atypical or non-tuberculous mycobacteria that can grow in the hot tubs. That's inhaled and can result in a hypersensitivity pneumonitis-like picture in some patients. So remember, the secondary pulmonary lobule in the center, you have the central lobular artery and the central lobular bronchiole. It's the inflammation around the central lobular bronchioles that give you these central lobular ground glass opacities or fuzzy nodules. It's also, because it involves the airways, it's associated with air trapping. So you can see areas of air trapping throughout the lungs. And if you want to see that, you'll see it better, of course, on expiratory views. There are non-fibrotic findings, ground glass, central lobular nodules, and then fibrotic findings, traction bronchiectasis. In very late stages, you might even have honeycombing with hypersensitivity pneumonitis. So the non-fibrotic findings, ground glass, small airway disease, diffuse distribution, fibrotic findings. You can still have ground glass, the small airway disease, but we look for fibrosis, and it might be diffuse or upper lung predominant in terms of the distribution of the fibrosis. So ground glass, central lobular nodules, air trapping, fibrosis, especially the parabronchovascular and upper lung distribution. Emphysema, air trapping, that's also associated with hypersensitivity pneumonitis. So the non-fibrotic changes, central lobular ground glass nodules, another example here, nodules are somewhat smaller. Another nice example of central lobular ground glass nodules, non-fibrotic HP. Air trapping, mosaic attenuation, actually mosaic perfusion, these areas of air trapping. There's a particular sign that is associated with that. What do we call the sign? The head cheese sign, right? So that's just these areas of lobular air trapping with ground glass and normal lung, that whole mixture is called the head cheese sign. Okay? Inspiratory-expiratory views, these can be useful to show you the air trapping in these cases. So some mosaic attenuation here, but much easier to see the mosaic perfusion on the expiratory views with hypersensitivity pneumonitis. When it becomes fibrotic, we'll get architectural distortion, reticular opacities, traction bronchiectasis, but always, if you have fibrosis in the lung associated with air trapping, if air trapping or emphysema is predominant, always consider hypersensitivity pneumonitis. So fibrosis and air trapping, think about HP. One of these patients has HP, one has idiopathic pulmonary fibrosis. Which is which?
IPF on the right,
So this one you think is IPF, why?
and it's basal predominant.
Basilar predominant, right, basilar predominant fibrosis with traction bronchiectasis. This one is more upper lung predominant. Also, this one has air trapping, lots of air trapping associated with that, okay? So fibrotic HP can be upper lung predominant, peribronchovascular fibrosis. It is associated with air trapping and ground glass opacity. So when we see fibrosis and air trapping, include HP in your thinking about that particular case, okay? Fibrotic HP, air trapping, traction bronchiectasis, usually not so much honeycombing as opposed to IPF, basilar predominant honeycombing with IPF, usually not as much air trapping as we see with HP, all right? It's important to consider the diagnosis because they do respond to steroids and removing them from the offending environment. Some of the opacities that we see can resolve with proper therapy, okay? All right, any questions? Okay, quiz next time, study for your quiz.